Hello everyone, good morning. One more lecture about macrocytic anemias, and the story is again the continuation of the anemias which we are discussing. And as I told you about the MCV levels, mean corpuscular volume, whenever it is less than 80 femtoliter, then it is microcytic anemia. When this is between 80 to 100, it is called as normocytic. Whenever it is more than 100, it is macrocytic. So, for example, um, we are discussing macrocytic anemia. Uh, like you got a patient and you found like the RBCs are less, like hemoglobin levels are less, and then you decided, okay, this is anemia. What you did is you send the next step in the CBC when we evaluate, you are going to check the MCV. And for example, if you will found in MCV that the MCV is greater than 100 femtoliter, which means that this is what type of anemia? This is macrocytic anemia. So when it is macrocytic anemia, then the next step is you must know what are the causes of macrocytic anemia. So the causes of macrocytic anemia can be remembered by a mnemonic written in many books: A, B, C, D, E, F. Though I don't like this mnemonic again because the things are not in the fashion which it should be. Like tell you the mnemonic of remembering what you can say the microcytic anemia tails. In that one, I, which is iron deficiency anemia, comes on the third one. It should be coming on the first one. But again, see, you can remember it by simply remembering A is for alcoholism, B is for B12 deficiency. So B is for B12 deficiency. Okay. C is for compensatory reticulocytosis. D is for drugs. And what kind of drugs? Of course, we'll talk about that. Endocrine, for example, in hypothyroidism. Okay. And the last one is folate. So actually what I want it to be, it should be like this, that vitamin B12 and folate and alcohol, they should come on 1, 2, 3 numbers exactly. So now one thing to understand about macrocytic anemia, one thing when it is established that someone have macrocytic anemia, the other thing which we do is we check like what is the morphology. Okay. What is the morphology means, like simply how the cells look like. So of course morphology, to check the morphology, what they do, like they see the cells under the microscope. So we classify macrocytic anemia into the further classification simply is the one of the type is called as megaloblastic anemia. Megaloblastic anemia, or and the other one is non-megaloblastic. Now, what is megaloblastic and non-megaloblastic? Simply, these are the changes which we can see in the cells. Okay, so when the changes are there, we call it as megaloblastic anemia. When the changes are not there, we say it as non-megaloblastic anemia. And simply, you have to remember that of course the RBCs are larger in size because the MCV, mean corpuscular volume, the volume of the cells is higher than what is as the normal. So what we found that when we found hypersegmented neutrophils, and in the RBCs they are large, of course, because it is macrocytic. Their shape is like oval, and they have small some small nucleated precursor is there. Okay, inside the cell, nucleated precursor they can see inside the cells. So these are the megaloblastic changes, okay, which we can see. And when these changes are not there, simply the RBCs are large but no nucleated precursors, and the neutrophils, they look normal. Okay, so we call it as non-megaloblastic changes. Now, why we divide it into these two categories, guys? Because the vitamin B12 deficiency, folate deficiency, can give, and also the drugs, they can give megaloblastic type of anemia, whereas all the other cause can give non-megaloblastic anemia. So this is like how we proceed when we have to make the diagnosis, okay, in the patient. Now, one thing, of course, like which we must know is what is the importance of B12, vitamin B12. Vitamin B12 deficiency is, you can say, it's not so common. And for example, if you will stop taking vitamin B12 from today, it takes a lot of time, you can say, to develop the symptoms. Okay, so what we are discussing right now is vitamin B12 deficiency anemia. Okay, so now our focus of interest is this one. Vitamin B12, as you know, it is also called as cobalamin. And cobalamin deficiency or vitamin B12 deficiency, they are the same things. Okay, so it is also called as cobalamin. Okay, and now, um, like, as you know, we are discussing anemias, guys. So remember, whatever anemia is there, the general symptoms of anemia, like, fatigue and all these things, like, tiredness, and you can say palpitations and dizziness, or that shortness of breath, all these things can be there. Or like even some more serious symptoms can be there. But some of the anemias, like in iron deficiency anemia, we remember about chylonychia, we remember about Plummer-Vinson syndrome, which is specific for iron deficiency anemia. The thing about vitamin B12 deficiency anemia, which you have to remember, is the special thing. It gives neurological symptoms. Okay, it gives neurological symptoms. What kind of neurological symptoms? Of course, we are going to discuss it in a while. Um, so, simply, whenever anyone have what you can say, vitamin B12 deficiency anemia, and we always check, what you can say, either there is neurological symptoms are there or not, because some of the symptoms are irreversible. So that's important, you can say. It's very important to treat it within time. Okay, um, like before this thing can occur. Okay, so remember, like, the general symptoms of anemia will come in any type of anemia, but specific symptoms, we like clinically, on history, on examination, we can look for that, just to know what kind of anemia is there. So what is that, like, sources of taking vitamin B12? It is present in eggs, it is present in meat, it is present in milk, it is present in fish. Okay, so simply, you can say, there is a lot of things in which, like, this thing is present. So if in the causes, for example, as I told you, that it is present in egg, milk, meat, fish. So like, if you will see that, most of the things which vitamin B12 have, like, which contain vitamin B12, is basically the diet, when person is taking all the his energy from all the different parts of our nutrition. So there are people, like, there are many religions, for example, in which, for people, they are strictly vegetarian, so that, they don't eat any kind of meat, they don't eat any type of meat products, and they don't eat anything which is coming from the animals, um, even eggs. Okay, so the people who are strictly, you can say, vegetarians, they are the one who can develop this kind of anemia. Okay, so of course, like, and malnutrition which should come. Okay, malnutrition in which you are having not just one deficiency, rather a lot of deficiencies. Okay, now the important thing to know that how vitamin B12 is absorbed from the body. So basically, we have intrinsic factor in our body or saliva. Whenever we eat anything, the intrinsic factor. It is like the vitamin B12 is bound with the intrinsic factor. Okay, and now what happens is, if there is no intrinsic factor in the body, so what will happen that vitamin B12 cannot be absorbed, or simply you can say you must have intrinsic factor in the body, so that when you will intake the like vitamin B12 in diet, so it should connect with intrinsic factor and then it will be absorbed in the body. If there is no intrinsic factor in the body, so it cannot be absorbed. So now what happens in some of the patients, it's an autoimmune type of condition in which the auto antibodies, they basically you can say destroy the gastric parietal cells. Okay, so what happens is, simply in some of the patients there is auto antibodies, and which destroy the gastric parietal cells. Okay, and what happened is, of course, gastric parietal cells are the one, our stomach is full of acid, so they cannot produce acid, so this condition is called as achlorhydria. Okay, and also, what happened, like, due to this achlorhydria, they cannot secrete they cannot secrete intrinsic factor. Okay, so when there is no intrinsic factor, like, it is not going to absorb, simply. So when you don't have intrinsic factor in your stomach, vitamin B12 which you are taking cannot combine with intrinsic factor, and when it will not combine with intrinsic factor, it is not going to absorb in the body. Okay, so and one of the thing, guys, okay, when this is the case, we call this condition, it's an autoimmune condition. Okay, we call this condition as pernicious anemia. Pernicious anemia. One thing to understand, guys, vitamin B12 deficiency anemia doesn't mean like it is only pernicious anemia. Pernicious anemia is one of the cause of vitamin B12 deficiency anemia. It's an autoimmune condition, and whenever someone have any autoimmune condition, they can have multiple autoimmune conditions. They may have. Okay, so gastritis, for example, it have the same thing, due to inflammation of the gastric lining, they cannot produce intrinsic factor. One of the thing, for example, someone who don't have gastric area, what is that condition is? Post gastrectomy. It can be removed for multiple causes. Of course, like, this is not our discussion right now. And now vitamin B12 get absorbed in ileum. Okay, so any conditions, you can say, which is going to destroy, or which is going to damage the mucosa of the ileum, of course, like, in that case, nothing can be absorbed. So vitamin B12 cannot be absorbed, even in the presence of intrinsic factor, because the absorption area, like iron, is absorbed in duodenum, or in the first part of the intestine, whereas this one is absorbed towards the end, ileum. Okay, so there are many conditions, which can damage the what you can say, ileum. So malabsorption can be written for that. Okay, malabsorption or malabsorptive conditions, for example, Crohn's disease is there, for example, celiac disease is there, okay, and so on and so forth. Okay, there are many other causes like pancreatic causes or insufficiency can be there. So this is the thing, very like not so important cause, but fish tapeworm, when someone is affected with this thing, they cannot, for example, someone don't have ileum, like they resect it for any type of condition, maybe carcinoma, so resection of ileum, of course, like they cannot absorb because the site which is going to absorb is not there, so of course the person, they cannot absorb vitamin B12. This is the cause, as well as certain drugs, they interfere with the absorption of what you can say vitamin B12. Okay, like proton pump inhibitors. Okay, there are many other drugs as well. Neomycin, metformin is one of the, by the way, I should add metformin. Why I am adding metformin? Because it's a very commonly used drug for in diabetic patients. Okay, um, and some rare genetic causes can be there. For example, intrinsic factor receptor defect. Okay, like it's a genetic disorder in which the receptor for intrinsic factor is damaged. So of course, when the receptor is not there, intrinsic factor cannot be absorbed from the body. So this is what you can say the causes of vitamin B12. Just pay attention, guys. Pernicious anemia is an autoimmune condition. It is one of the cause um, uh, of a vitamin B12 deficiency. Okay, so as I was telling you, that it takes a lot of time. If someone will stop taking vitamin B12 today, it takes a lot of time to develop um, what you can say the deficiency of vitamin B12, because like all of the adults, most of us, we have a huge stores of vitamin B12 in our body. You can say on an average 2 to 5 milligrams in adults, it is there, and out of that, 50% is stored in the liver, and we lose around 0.1% every day of vitamin B12, which means, and by the way, this amount which we lose is basically much of that even get reabsorbed. Okay, so see, we have a huge amount in the body, we lose very little amount, and all the amount which we lose every day basically uh, is reabsorbed. So like someone should be like taking a vitamin B12 deficient diet, or any of the causes should be there for a long period of time. Okay, so you can say it takes, you can say, up to 5 years to develop this deficiency if you will stop taking today. So if you're not taking vitamin B12 in everyday diet, so it doesn't mean you are going to develop the deficiency so quickly. Okay, rather it takes a lot of time. So now, as we are discussing vitamin B12 deficiency in anemia, so one thing to mention here is important. I told you that this is an anemia which gives uh, which gives megaloblastic changes. Okay, so simply remember, like vitamin B12 deficiency anemia is the anemia in which you will find megaloblastic changes. It is macrocytic anemia. It gives neurological symptoms. I am saying this and again and again and again, so that it should be in your mind that vitamin B12 deficiency anemia do gives neurological symptoms. Vitamin B12 deficiency anemia do give neurological symptoms. Okay. Now, talking about what is megaloblastic changes. Of course, like I'm not here to teach you pathophysiologies or the basics, but just to put this thing in your mind, vitamin B12 is basically doing two very important functions in the body. Okay, see, this is, for example, one of the things you can see over here. Okay, vitamin B12 is very much connected with folate. Okay, folate is converted into 5-methyl folate, and vitamin B12 is there, which is changing homocysteine to methionine. So it is changing homocysteine to methionine. Basically, the name of the enzyme is called as methionine synthase. Okay, so what will happen if vitamin B12 is not there? Simply, homocysteine will not be converted into uh, methionine. Okay, and when this is not going to convert into methionine, so what is going to happen? Which thing is going to build up in the body? Homocysteine, of course. So now, when the homocysteine in the body will be raised, we call this condition as um, cystinemia. Okay, homocystinemia. Of course, this is going to develop in the blood. So this is one of the function which vitamin B12 is doing. Okay. Now, why I'm showing you this thing, because okay, one more thing which vitamin B12 is doing can be seen by this one. See, but like this is a very good one. See, vitamin B12 serve as a cofactor for two enzymes, homocysteine methyltransferase and methylmalonyl-CoA mutase. Now, this is the enzyme, basically, you can see over here, which is changing methylmalonyl-CoA to succinyl-CoA. Okay. Now, one thing which is very important to mention here, guys, this one is very important to maintain the normal myelin sheath. Okay, myelin. You know what is myelin sheath? Myelin sheath is simply a protective covering on the nerve fibers. Okay, so it is a lipid-rich layer or fatty layer, in very simple words you can say, which is surrounding the nerve cells, or you can simply say this is the insulation. If you will see the electric wires, electric wires have the covering of that plastic or insulation. So this one is like the insulation which is there for the nerves. Okay, so these two functions are very important, and these two functions are basically very important to maintain the neurological system in the body. Okay, and whenever like the vitamin B12 is not there, so these two things are disturbed. Okay, these two, like homocysteine, it will not convert into methionine, and there will be hyperhomocystinemia. Okay, and the other thing is what I can mention it over here. Okay, I'm sorry, wait. I will delete this one for now. Cut. Okay, so you can see over here there will be what? Homocysteine is not going to convert it into methionine. You can see over here. Okay, so it is going to lead to hyper homocystinemia. Okay, so this thing is one of the thing, and the other function is methylmalonyl CoA is not converted into succinyl CoA simply. Okay, and now the important thing here is what? I'm talking about this thing because vitamin B12 is very essential for the functionality of our nervous system. Okay, because you can say this cycle is also called as one carbon cycle, and the proper functioning of the central nervous system is dependent on the one carbon metabolism, okay, that is taking place in the brain. Of course, like there is a lot of chemical or biochemical reactions going on in the body, and this cycle is very crucial or very important to for the formation of DNA, RNA, as well as the neurotransmitters, as well as the myelin sheath. Okay, now uh, what happens? As we know, methionine is what? It's an amino acid. Okay, and again, what is homocysteine? It's an amino acid as well. Okay, so now when methionine is not there, um, so it is going to you can say, create a lot of problem or pathology in myelin sheath as well as the neurotransmitters, okay, which both of them, they are very important to maintain the normal neurological development or functioning, okay. Now when the level of homocysteine, because see, homocysteine is not converted into methionine, when the level of homocysteine is going to raise in the body, okay, so it basically causes brain damage, okay, brain damage or cognitive issues simply, okay. And the other one, uh, which is, I'm talking about this one, methyl malonyl CoA is converted into succinyl CoA. Okay, so when this one, vitamin B12, which is cobalamin, it is not there, and this reaction is not going to occur. So what happens that this one is going to build up, methyl malonyl CoA is going to build up in the body, and it started getting converted because there should be some degradation. So succinyl CoA is not formed, so this methyl malonyl CoA will start converted into methyl malonic acid. Okay, so simply you can say, uh, uh, I think the short form of this thing is MMC or something like this, like methyl malonyl CoA, but I'm not sure about this thing, like what is the short form for this thing. But simply what will happen, that methyl malonyl CoA will keep on building up in the body, and it will start changing into methyl 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 malonic acid, okay, that is called as MMA, okay. So it is going to, like, what will build up, methyl malonic acid, MMA. So this thing is basically a myelin sheath, myelin sheath, myelin destabilizer, okay. It destabilize the myelin sheath, okay. Or simply you can, like, what is myelin sheath? This is simply fatty acids, okay. So there will be abnormal fatty acids in the myelin, which is abnormal. So simply due to that abnormality, there is the, like, dysfunction of the peripheral nervous system. So guys, hyper homocystinemia will give some cognitive issues, brain issues, central issues. Methyl malonic acid, this one will destabilize myelin sheath, which is basically in the fast tracts, or you can say the posterior tracts, fasciculus, gracilis, and cuneatus. So what will happen, that it is going to cause a lot of peripheral nervous system dysfunction, or what we simply can say is peripheral neuropathy, okay. So this is why vitamin B12 is very important in functionality of the central nervous system, okay. Now I think, like, it's enough for what you can say, the pathophysiology, why this thing is occurring. Now what are the clinical features, okay, uh, for this one, okay. Now clinical features of this anemia, first of all, remember, um, you can say the constitutional symptoms, constitutional, or like the regular analysis systems of symptoms of features, I will write, because symptoms and signs, okay, features of anemia will be there, okay, which will be present, like tiredness and dizziness and palpitations and shortness of breath and all this stuff, okay, they will be there. But the features which are typically related to this type of anemia, remember, neurological, okay. And neurological symptoms, like, of course, they develop slowly, but once they develop, of course, uh, the bad thing, some of the symptoms or signs, clinical features, when they develop, which are neurological, many of them, they are irreversible. So first of all, as I told you, when methylmalonyl CoA is not going to convert it into succinyl CoA, which need cobalamin or vitamin B12, simply methylmalonyl CoA is started converting into MMA, and it will give a destable type of myelin sheath, which means it will give peripheral neuropathy. Okay, now peripheral neuropathy, what happens, like when we treat these patients and we start giving them vitamin B12, some there is some recovery in peripheral neuropathy, but there is no complete recovery. So simply it is partially, okay, partially is not on the right, you can say it is variable, okay, irreversibility. So what it means, like simply ability. Okay, so simply what happens, like sometimes it recovers, sometimes it don't recover. Now guys, if you know what is the features of peripheral neuropathy, um, the posterior column, they are highly myelinated. The fast sensations like vibration, like proprioception, okay, uh, all these things, they are carried in the posterior column, which is highly myelinated. So they are the one which are badly affected. Okay, and these are the patients. They have tingling sensations, pain, and numbness. Okay, um, due to peripheral neuropathy. Now, uh, of course, like it is going to involve both of the lower limbs, so it will be symmetrical. Okay, and it affects the lower limbs more than the upper limbs, because the lower limbs, they have the long nerves, so they are the one which are first presenting. Okay, rest, like what is the peripheral neuropathy, these patients, they complain of tingling sensation, they complain of pain, numbness, altered sensation in the what you can say, in the limbs. Okay, and I'm not saying not upper limbs, but lower limbs are affected more than upper limbs. Now it damages the cord. Okay, uh, it is irreversible damage. So once it will develop, guys, um, it is not reversible. Remember one thing, it is called as second. Okay, what is second? It is subacute combined degeneration. Okay, so this one, peripheral neuropathy, which will affect the nerves peripherally, they will give pain, temperature, because it can affect any of the nerve, right? Numbness, okay, anything. But when there will be subacute combined degeneration, okay, what is going to happen? It is going to affect the highly myelinated tract, which is which one? Posterior columns. Okay, posterior columns, or fasciculus gracilis and cuneatus. So now, what is carried in posterior column? Vibration senses, proprioception, 2-point discrimination. Okay, so this condition is called as subacute combined degeneration. Now, this is a progressive degeneration, and it can affect the brain, nerve of the eyes. It can affect even the peripheral nerves, and the myelin sheath is damaged. If you are not going to treat it, axons will be damaged as well, or degenerated will be there. So simply, these are the patients who present with vibration problems, and these are the one which will be having proprioception problems. Okay, 2-point discrimination, like if you will close eyes and someone is going to touch you at, like, with a pin at one point of the finger, and with other pin, it is going to touch at some other point, and you can sense, like, there is 2 points which they are touching with the pins. This is called as 2-point discrimination. It's the same idea. When the smartphones they came, they can, in the start they can just sense one touch, but later on, nowadays, they like the smartphones, they can catch multiple touches on the screen. So our body can discriminate between 2 points, of course, like when it is given at some, what you can say, at some distance. Okay. Okay, not only these things, but like later on, they may develop visual problems. Okay. Visual problems, and of course, like everything is controlled by the spinal cord, like all the connections are coming from the spinal cord. They may have, in the males, erectile dysfunction as well. Okay. Erectile dysfunction can be there. So of course, like, if what's important here is like early treatment of this condition is going to give us good results. If you're not going to treat them, what is going to happen, that it is going to cause much bigger problems, and it is irreversible damage. And it can also affect the pyramidal tracts. So once they are affected, of course the patient is going to present with weakness. Okay. Paresis, you can say, and ataxia. Okay. So these are the features of the neurological features of this thing. And now, yes, we already discussed it can cause cognitive problems because of the collection, the accumulation of homocysteine, right? And now, yes, important thing to mention here is this is reversible. Okay, reversible. This one is reversible. Once you are going to treat that, they are going to recover from this abnormality. What are the cognitive problems? See, anyone whose cognition is gone or is disturbed, they will present with confusion, they can present with delirium, or they can present with dementia. Okay, so these things can be there. Now, like, guys, about cerebral problems, okay, you can also say this thing as psychiatrical problem, simply because, see, dementia or delirium, memory problems, all these things, sounds more like, you can say, um, psychiatrical type of problems. Okay. One of the thing which can be there, but though not so important, it can affect the cranial nerves. Okay. But very less often. Okay. Cranial nerves nerves can be affected as well, but not so important, not so commonly. Okay. But they can be affected simply. uh, One of the thing, no, again, not so important and not neurological, rather you can say non-neurological. The new research says, like, whenever the homocysteine level in the blood is high, so they also like they say, like, it's a risk factor for a risk for stroke, or other vascular problems. Okay. Not so important, vascular problems. So this is because of what? Hyperhomocysteinemia. Okay. So this is one of the thing you can remember. Okay. Now, like, I think this is more than enough for what you can say, the uh, macrocytic, like vitamin B12 deficiency anemia. How we investigate these patients? Investigate. Okay. See, investigations. Okay. And now, remember this thing, guys. How we can diagnose the patient? The patient came and he's telling you that I have I have the symptoms of anemia, and I feel numbness, I have this confusion, I have pain sensations, or have numbness and tingling sensations and burning sensations in the lower limb, especially. You will start thinking of, okay, maybe it is anemia. On history, you will inquire about what kind of diet he took. Either he have any other autoimmune condition. For example, if it's a female, multiple pregnancies, it can cause, or any gastrectomy done. Either he's on any special diet for celiac disease, either he has some sort of IBD, like inflammatory bowel disease, and things like this. So, of course, that will point towards, you can say, that the patient has some sort of anemia, and like the picture sounds more like you can say uh, vitamin B12 deficiency anemia. See, so like of course I'm going to write all the investigations. See, we do CBC. In CBC, I think now it should be uh, in your mind now what you will see in the CBC. Uh, Reticulocytes count will be low. Um, Anemia will be often if there is neurological symptoms. So the anemia most of the time is severe, and the MCV will be for sure more than 100. Okay, so these are the things. Okay, and by the way, sometimes when the anemia is so severe, they may have neutropenia as well as thrombocytopenia, like simply neutrophils as well as thrombocytes, they will be decreased as well. Now, of course, like when it looks like the picture looks like vitamin B12 deficiency, what you are going to do? You are simply will ask for serum B12 levels, okay? And one more thing, guys, because folate deficiency have almost the same picture, but there is a huge difference. I will talk about when I will talk about folate deficiency anemia. I'm not talking here because that is so short topic. I have to give you some information over there as well. So I will include this thing over there. So we will ask the patient to go for serum B12 level. We will ask the patient to go for serum folate levels as well. Okay. So now, like the people, by the way, who have low serum B12 levels, basically it lead to low RBC folate levels as well. Why? Because if you will remember, like the picture I show, both of these things are connected: the folate as well as the function which vitamin B12 is doing. So they have the low RBC folate level. Okay, so this thing, and now one of the thing which we will ask them to do is in this case will be to check to do the blood film. Now what is blood film? Blood film is basically they see the cells under the microscope. What they must see is hyper segmented neutrophils. Okay, if you remember, this is the thing which I told you, which will point towards like it is megaloblastic changes are there or not. Okay, so of course, like we don't go for much investigations in reality, but here I have to talk about all the investigations. So there is one test called a Schilling test. I will talk about that thing in a while. But you can do a bone marrow. This one you can do in anything. You can do a bone marrow biopsy. You can check what's going on there. You can found hypercellularity. You can found RBC's precursors or with less mature nuclei. Okay, in them. Of course, I explained this thing before. And we can also ask for bilirubin levels, okay, as well as we can also ask for LDH levels. Why? Because both these things can be elevated due to increased breakdown of cells in the bone marrow. Bilirubin comes from where? It comes from the breakdown of the cells. Okay, now the most interesting test in this one is called as Schilling test. Guys, this one is not done these days. Okay, and now what is the importance of this test is simply it is to differentiate. Okay, it is to distinguish or differentiate between pernicious anemia from the other causes. Okay, now see why this thing is important, because you have to differentiate either the person have pernicious anemia or any other cause by which he is getting this kind of vitamin B12 deficiency. Um, Let me tell you again, repeat you, what is pernicious anemia? It is an autoimmune condition. What is there? There is antibodies. What kind of antibodies? The the antibodies which are there in pernicious anemia are anti-intrinsic factor antibodies, okay, or anti, I already explained this thing, parietal cell antibodies, okay. So when they have this thing, of course they are the one, either they are going to destroy the intrinsic factor or either they are going to destroy the parietal cells, and this will lead to lack of intrinsic factors, okay. Now what is this one? I told you this test is not done nowadays much, okay, because of newer tests which are available. It is rarely done nowadays, okay, but this one like very important. Now what is the basic of this test? See, we have to differentiate either the person is getting deficiency due to vitamin B12 deficiency in the diet, or due to malabsorption, or simply you can say this test will catch the cause, either it is malabsorption, either it is less intake, or either this is the deficiency of vitamin B12, okay. Now see, what we give, we radio label. You know what is radio label? Radio label is like when you will, for example, iodine, if you are going to like label the iodine with some radioactive thing, so the iodine which is present in the body can be differentiated with the iodine which you have given from outside, okay. So we give radio labeled B12, which means when we give the patient a radio labeled B12, we can differentiate, like by taking, for example, the patient urine. If radio labeled B12 is coming, it means this is the B12 which we give. If non-radio labeled or simple B12 is coming, it means this B12 is coming from some others, like from the body inside, okay. Now see, we give them radio labeled vitamin B12 dose to the patient, okay. Most of the time 1 microgram is given, okay. We give it to the patient per orally, okay, per oral, mostly 1 microgram, and this is called as the tracer dose, okay. So radio labeled, we label this B12 so that we can catch later on in the urine, either it is the one which is we are going to see. How we are giving this? We are giving this per orally in a tablet form, okay. Then we give unlabeled, like a B12 which is not labeled, okay, or you can say the one which you can get from egg, by the way, the one which you can get from the meat, okay. We give this one unlabeled vitamin B12, okay, IM, intramuscular, okay. I will write fully, intramuscular, by the help of the injection, okay. Around 1 hour later, you can say 1 hour later of giving the tracer dose, this one is called as flushing dose, okay. So we give a radio labeled per oral tracer dose, we give unlabeled intramuscular flushing dose, okay. Why we are giving this thing? We are giving this thing so that this dose which we are giving intramuscularly to saturate all the tissues in the body, okay, so that this one which we are giving through the mouth should be absorbed in the blood. It should not get any place to bind in the body, it is going to be excreted in the kidneys in the form of urine. Okay, just for many who could not catch the things, we want all the tissues in the body to be, we give, by the way, 1 milligram, this one 1 microgram, this one 1 milligram, a huge dose. We want all the tissues in the body to be bounded or saturated, okay, saturated by unlabeled dose, okay, or by the flushing dose, so that the labeled, the radio labeled B12 cannot find any site in the body to bind. Okay, so what will happen? Of course, peroral one will be absorbed from the blood, from the intestine into the blood, started circulating in the body. It will be excreted in the urine. So what we must get in the urine? We must get the radio labeled one, because we saturate all the body stores with the unlabeled one. What is going to happen? Okay, then what we do, sorry, just give me one. Okay, then what we do, after 24 hours, we measure the urine B12. Okay, of course, which one? The radio labeled one. Okay, after 24 hours we measure the urine B12, of course the radio labeled one. Okay, because we had radio labeled, so we know how much tracer dose is presented in the urine. Okay, okay, normally in the normal people, normally greater than 5%, okay, excretion is there. Okay, now this excretion we can only see if the deficiency of vitamin B12 is due to dietary causes. See, why? What will happen if there is no intrinsic factor? If there is no intrinsic factor, this can be absorbed? No. It can appear in the urine? No. So, okay, in case of malabsorption, can it be absorbed? No. It can appear in the urine? No. So when this functionality is there, it can be, the intrinsic factor is there, this one can be absorbed, and it cannot found anywhere in the body to bind, because we saturate by giving unlabeled B12, so it will excrete in the urine, which means the cause is not intrinsic factor deficiency or malabsorption. Remember, the cause is not, make it capital, very important, intrinsic factor deficiency or malabsorption. So the cause is what? Hence, the cause is dietary. Okay. Now guys, if the cause is dietary, done. Improve the diet. For example, we cannot find, for example, okay, you can say, second case, we cannot find B12 radio labeled in the urine. What can be the possible causes? The possible causes can be intrinsic factor deficiency, okay, like pernicious anemia. Okay, the cause can be malabsorption. Okay. Now the malabsorption can be reversible or irreversible. For example, celiac disease malabsorption is irreversible. Celiac sprue or Crohn disease, these kind of malabsorptions are irreversible. But in some of the cases, what happens is there is bacterial overgrowth in the intestines. So if we are going to kill that bacteria, we can reverse that malabsorption. So what we do, when the cause is not dietary, we cannot found radio-labeled B12 in the urine, we give radio-labeled B12 plus intrinsic factor. So if the cause is pernicious anemia and we are giving what? B12 with intrinsic factor, what will happen? Then we will found excretion of radio-labeled B12 in urine. Understand? When the cause, when we give radio-labeled B12 with intrinsic factor and there was deficiency of intrinsic factor, so now it will get it will have started appearing in the urine. What it means, the deficiency was just of intrinsic factor. But for example, case number 3, third case, still you give them, we cannot found radio-labeled B12 in urine, we will give radio-labeled B12 plus intrinsic factor plus antibiotics. Why? Because we want to kill the bacteria. Like this is one of the cause, which like this could be one of the cause, right? By which the absorption is not there. So if, what will the result? If the cause is bacterial overgrowth, then we will get it in the urine. And the fourth case is simply you cannot found. Okay, so here if this is the case, the cause is what? In second case, what is the cause? Pernicious anemia. Okay, in this case, what was the cause? Sorry. Yes, of course. And if I will give with antibiotics, what will be the cause? Bacterial overgrowth. And if you cannot found even after giving this any in the urine, then what is the cause? It is some malabsorption, some irreversible malabsorption. Guys, hope you understand, like celiac disease, like Crohn disease, okay? Hope you understand this this Schilling test. So easy, okay? And now what you can say, what is left is simply what you can say, the treatment. Okay, so how we treat this kind of anemia, which is vitamin B12 deficiency anemia. If the cause is dietary, whatever is the cause, guys, okay, one thing, remember, if the cause is pernicious anemia, if the cause is pernicious anemia, you will keep on giving oral dosages, it cannot be absorbed. Okay, so that's why we have to give them, we have to bypass this GID, IM injections of vitamin B12 or cobalamin. Okay, and this is an injection which, by the way, which is misused a lot. Anyhow, that's a different story. So we give them IM injection of vitamin B12. If the cause is dietary, okay, you can give them per oral vitamin B12. Okay, if the cause is dietary, of course, like the per oral will work. Okay, so this thing, and we continue the treatment for at least 3 months. Okay, simply to make up the deficiency of what you can say of the vitamin B12. Okay, and whenever we give through the mouth, we give high dosages, guys. Okay, because the absorption is not high. Okay, so we give like 1 to 2 milligram every day, like in a very high dosage by oral route, of course, because simply the absorption is not so good. Okay, just few words about folate deficiency anemia, and then of course, like, this topic will finish, and I will tell you what are the drugs in this one, folate deficiency anemia. Okay, so folate deficiency anemia, guys, this is very uncommon. Okay, especially in developed world. Why? Because simply, like, much of the developed world, the flour which we use to make bread, like in 1990s, I think, or 1980s, they started fortifying flour with folate. Okay, so if you are buying like any flour from the market, it is already what you can say, fortified with folate. So very, very, very less chances nowadays you are going to develop that. Like, if someone is not taking if someone have any risk factors to develop folate deficiency anemia, it takes 3 to 6 months to develop this anemia. Okay, to develop this anemia, in case someone is taking folate deficient diet. Folate is present in, remember, greeny things, green leafy vegetables, so eat more green. If you are buying the flour from like the processed one, it is already fortified with folate, so that's a very good thing. And now, what are the causes of deficiency of folate? Just remember few very important thing, alcoholism. Okay, uh, poor intake, of course. Okay, in developing countries, not in developed countries. Malabsorption, same malabsorptions which I talk about in vitamin B12 deficiency, celiac disease, inflammatory bowel disease, bacterial overgrowth, and things like this. The interesting thing is drugs. Okay, now many drugs which are used for a long period of time, like chronically they give for rheumatoid arthritis, for many conditions, these drugs are called as antifolate drugs. Remember, methotrexate. Okay, you forget any name of drug, never forget methotrexate. It's an antifolate drug. It is given in many treatment of many things. Okay, rheumatoid arthritis and many other things. Anticonvulsants, like the people who like anti-seizure drugs, phenytoin. Okay, it can cause. And OCPs, oral contraceptive pills, can cause, but not so important. Multiple pregnancies in developing world, okay, and hemodialysis. The patients who are on like kidney failure and they are on hemodialysis. So clinical features, guys, quickly, very easy. General symptoms of anemia, of course, they will be there, and some of the people, they develop mild jaundice. They may have glossitis, and sometimes they have confusion. Uh, Remember, this both are connected. Okay, guys, remember this thing: folate don't cause any neurological symptoms. Okay, because folate is not needed in those two pathways for which vitamin B12 is playing a role. Okay, so remember this thing: folate doesn't cause neurological symptoms. Investigations, very easy. We do CBC. Okay, we go for B12 levels, and we go for folate levels. Okay, because we have to rule out all the time, this by B12 as a cause. And management is again so easy. Management is simply giving them folic acid. Folic acid is recommended to all the pregnant women as well, uh, in the first 3 months of pregnancy or the first trimester. Okay, so per oral we give them, okay, 1 to 5 milligram around, and we have to give it to 1 to 4 months. So, like, that's all about megaloblastic anemias, guys. Rest, like, see, drugs are also caused, alcoholism is caused, like, covered, and all this causes are covered. So, hope you understand this all story. Okay, and thank you so much.